So welcome everybody. I'm Veronica Barry from Healthwatch Oxfordshire. We're really pleased to have three speakers here today to talk about the new Pharmacy First scheme that was launched in January with the aim of reducing pressures on GPs by enabling people to go to the pharmacy for some direct health and care support, which will be explained in a minute. So we're really pleased to have Julie Dandridge here. She's Head of Pharmacy, Optometry and Dentistry for the Buckinghamshire, Oxfordshire, Berkshire West Integrated Care Board. Dan Leveson, who's probably familiar to quite a lot of you, Place Director for Oxfordshire for the Integrated Care Board. And David Dean, who is the CEO of Community Pharmacy Thames Valley. So we're going to have a short presentation both from Julie and then from David. And then if you would like to put questions, you can put questions either into the chat or at the end by raising your hand. So they'll speak first and then we'll hand over to questions and discussion about the things that we've heard. So thank you very much. We'll hand over to Julie.
Thank you, Veronica. And it's good to be here to talk about community pharmacy. Some of you may have seen me previously where I've talked about the primary care strategy or about general practice too. But today I'm here to talk about community pharmacy. And Erica, if we could bring up the first slide, please. What I wanted to do was just give you a little bit of an introduction to community pharmacy across Oxfordshire. And then my colleague David will go into some of the details about Pharmacy First. David and I have been doing a double act around the BOB, the Buckinghamshire, Oxfordshire and Berkshire West footprint, talking about this. So across Oxfordshire, we have 99 community pharmacies. Some are associated with some are located in GP practice buildings, others are in more rural communities. But actually, they deliver a lot of healthcare to our population. And I've just given an estimate of some of the numbers of some of the services that they do. So nearly 334,000 prescriptions are dispensed. And if we think most prescriptions have more than one item, more than one medicine on it, that's a lot of medicines going through our community pharmacies each month. But it's not just dispensing medications that our community pharmacy offers. There's a whole load of other services which I will leave probably David to go into in a bit more detail. But it's important to remember some of the others. You can go to a community pharmacy and have your blood pressure checked. If you start on a new medicine, you can be referred to have that medicine reviewed so that you are you've got someone to ask in terms of the community pharmacies. Also to say, you know, community pharmacists have been through university, have done a 4-year degree, have done some registration exams, etc. So they are fully qualified individuals, and I know that's something I often get asked, and I probably need to declare a bit of a conflict in that I am a pharmacist by training and by degree, although I no longer practice in community pharmacy or in hospital pharmacy. If I could have the next slide, please, Erica. Did just want to highlight a question we often get asked about community pharmacy closures. Many of you will be aware that we've had pharmacies particularly in Sainsbury's supermarkets, close, particularly the Lloyd's brand. And we had quite a few pharmacies across Oxfordshire absolutely absolutely close. So we do know that we have had less. So Lloyd's Pharmacy closed their pharmacies in Sainsbury's supermarkets, and also sold those ones that are on the high street onto new owners. Thank you, Sarah, for your question. So by community pharmacy, we mean those pharmacies on the high street, those ones where you walk into to get your prescriptions dispensed, or which sell healthcare products. They are all controlled by national regulations, by the National Pharmaceutical Regulations, which determines the services that they have to deliver, but also where and what times they need to open, what services they need to offer, how they can set up new ones. Funding comes nationally, and the Integrated Care Board gets a defined pot to pay community pharmacy for their services, which include dispensing and all those other things I included on the other slide. The amounts that are paid are set nationally, and it's very much an activity-based service. So if the pharmacy doesn't dispense any prescriptions, they don't get paid anything, which is different to some of our other services. So just going back to the closures across Oxfordshire, a pharmacy can announce that it's closing at any stage. But when we do that, when we do hear that, we do look at what are the other options that we have in terms of that area. And we've really seen a shift from some of the big companies like Boots and Lloyd's to some of the smaller the smaller ownerships, who are really investing in making sure that community pharmacy on the high street is valuable and can support the wider thing. The local authority and health and wellbeing boards are responsible for defining where there are pharmaceutical needs, pharmaceutical gaps, community pharmacy gaps, and they will and they determine where there might be a gap, and then people can apply to say we'd like to fill that gap, and we can get new pharmacies. It's all controlled, as I said, through the NHS pharmaceutical regulation. So it is quite complex, but at the moment, we think we've got a good variety of community pharmacies offering a wide variety of services. If we can just go on to my last slide before I hand over to David. I think I was here talking to some of you previously about our getting feedback on our primary care strategy, which actually is being talked about at this very minute at our board meeting in Aylesbury today. And that picks up how we see our primary care services going forward into the future. That includes general practice, but also covers the other services like community pharmacy, optometry and dentistry. And I think that's really exciting for community pharmacy to be there. And you'll hear a bit more about how community pharmacy is supporting general practice going forward. Just wanted to mention the NHS app as well, which has real benefits for ordering repeat prescriptions and for tracking the dispensing of them. So the NHS app is a great help to community pharmacies in being able to follow up repeat prescriptions and making people aware of when they are ready. Looking at some of the other things going forward, I think the big thing, as we are about to come on to, is the Pharmacy First scheme, which was introduced on the 31st of January. So we're still in the early months of it, but I know I'm going to ask David to give us you a bit more of an update in terms of what that is and how it can help support our population. Thank you, David.
Thank you very much, Julie. If I could have first slide, please, Erica. I just want to thank Veronica for the invite today, and it's always a pleasure to try to talk about pharmacy and increase people's understanding really about what pharmacy can do and what they can offer. Come next slide, please, Erica. Okay, so just a little bit about who we are. We're an LPC, so Local Pharmaceutical Committee, so the equivalent of what an LMC does for GP practice. So we're a non-profit, we're not a commercial entity, and we're a statutory body set up by an Act of Parliament, and we represent 328 community pharmacies across the whole of Oxfordshire, Bucks and Berkshire. And we work with local authorities, systems, public health, patient groups, GPs, and everyone else to try to get the best for patients and also getting the best out of community pharmacy. We've just got 2.5 employees, and our salaries are paid for by a tiny, tiny fraction of a penny per prescription that patients present in a pharmacy. Next slide, please. So within Oxfordshire, we do have 99 pharmacies, as Julie pointed out earlier. We did have 115 just over 2 years ago. So it just shows that how much financial pressure community pharmacy is under at the moment. 6 of those pharmacies within Oxfordshire are what we call 100-hour pharmacies. And I've put that in inverted commas because actually the government changed regulations not long ago to allow those 100-hour pharmacies to only open for 72 hours to help them with their financial situation. And as you can see, we've got those 6 spread quite widely across Oxfordshire. And included in that 99 pharmacies, we've got 2 that we call distance selling pharmacies. So these aren't there to see patients on site, but actually they commit to delivering a prescription to anywhere in the country, but they can actually offer some services as well remotely. Next slide, please, Erica. And just to really build on what Julie was saying earlier around which services are provided by pharmacy, they're split into 3 groups. So essential means a pharmacy has no choice. If they've got an NHS contract, they have to dispense NHS prescriptions. They will collect your old medication, apart from needles, from a household. So anything that's in excess of what you've needed, if it goes out of date, they can collect those happily for you. We have our new medicine service to advise patients on getting used to anything that's new for them. We do a discharge service from hospitals for patients leaving who are on complex medication, but they also offer healthy living advice around exercise, smoking, alcohol, and of course, because of what we call over-the-counter solutions that you may have that are outside of prescription, pharmacies are there to offer what we call self-care advice. So to alleviate pressures on other parts of the system, if there's a fairly cheap solution that you can just buy over the counter, then pharmacies are there to help you with that as well. And then we have advanced services. So these are optional for pharmacies, but for example, Pharmacy First, I think it's 99% of all pharmacies actually are registered for Pharmacy First, and we'll talk about that in detail later. But they also offer oral contraception now, so initiation and continuation of oral contraception for women, hypertension case finding, so that's free blood pressure checks for anyone over 40 who hasn't been previously diagnosed. We obviously have a big part to play in the vaccination programme, flu since 2017, and obviously more recently with COVID. And, you know, that's been an amazing journey for community pharmacy and a brilliant success actually for the NHS. And we're also offering free lateral flow devices for a very select eligible cohort of patients at the moment. But we also commissioned by local authorities or systems to deliver things like the morning after pill, helping patients recover from substance misuse, needle exchange, providing medication for end of life through palliative care, antivirals for both COVID and flu. And we also offer, with Julie's help actually, very fundamental in this, a minor ailment service, so over-the-counter medication free of charge for those patients on low income, which are working really hard to try and get up and running for those that really need it. Next slide, please, Erica.
Introducing Pharmacy First, the NHS service that enables patients to ask pharmacies for help with a range of common minor conditions. Pharmacy First makes it simpler for everyone to get healthcare advice and treatment more quickly without needing a GP appointment. Expanding on the role that community pharmacies have already been playing through the Community Pharmacist Consultation Service, Pharmacy First allows GPs and other health professionals to refer patients to a pharmacy for a minor illness consultation. And, for the following 7 conditions, a supply of an NHS medicine where clinically appropriate: sinusitis, sore throat, acute otitis media, infected insect bite, impetigo, shingles, and uncomplicated urinary tract infections in women. Referrals to the service can be made by general practices, NHS 111 and 111 online, 999 services, primary care out-of-hours services, and urgent and emergency care settings, such as urgent treatment centres and emergency departments. As experts in medicines and managing minor conditions, pharmacists have the necessary skills to supply medicines where they are needed and appropriate, helping to ease the pressure elsewhere in the healthcare system. And new IT developments will ensure any treatment supplied is recorded in the patient's GP record. In instances where the pharmacist is not able to help with the condition the patient is presenting with, they will be referred to the appropriate healthcare access point, such as their GP practice or emergency department. However, previous experience from the Community Pharmacist Consultation Service suggests this will only be needed in a minority of cases. Over 90% of community pharmacies in England signed up to provide the Pharmacy First service within the first month, making healthcare advice and treatment more accessible. It is hoped that the service could help reduce pressure on general practice by as much as 10 million appointments per year. And that is only the start. Please help make Pharmacy First a success by referring any patients with minor conditions to community pharmacy.
Thank you, Erica. If you could go to the next slide, please. So that was a video that's been put together by our parent organisation, Community Pharmacy England, to help practice teams understand what Pharmacy First is. So I thought that's quite a nice way to lead you into it. The only thing missing from that presentation is it doesn't talk about the ability for a patient not being referred by GP or 111, but the ability to walk into any pharmacy and actually with presenting any of those 7 conditions, it possibly leads to a consultation with the pharmacist and ultimately to treatment for that condition. So when we talk about why we're doing Pharmacy First, if you could just click, please, Erica. That's right. So for GPs, obviously, it's a fantastic way of releasing capacity. And we've seen it in 1 or 2 surgeries now where they've actually, by really taking up the use of Pharmacy First, is making longer appointments. So going from 10 to 15 minutes to allow a better conversation between the GP and their patients, and possibly a focus on complex patients. The link to the video is in the slide deck and it's on YouTube, so you'll be able to see that or share that at any time. Erica, if you could click that, please. So for pharmacy, of course, it's probably the biggest thing that's happened to pharmacy for 10 years now in terms of a new service. And as Julie will testify, the favourite thing of a pharmacist is to have a great conversation with a patient. And obviously, Pharmacy First is just building upon the skills that every pharmacist has got. We've had to build on that in terms of enhancing clinical examination skills, and we've trained or supported the training of over 450 pharmacists across Bob. And also, we've had flat funding now for several years, but a portion of money has been put to one side for Pharmacy First. So if we can make this a success, it actually strengthens the financial viability for community pharmacy in your community. And then, Erica, finally, for patients, obviously it means quicker access to appointments, because once you've had that referral from your GP, or you've got just walk into a pharmacy, you can be seen almost straight away. And obviously it gives you much better access to treatment. And we found that, patients are making use of this when they just can't get hold of an appointment with their GP. Next slide, please. So in Oxfordshire, we've broken down the numbers, and the 35 is because it's for one day in January, 31st of January. But as you can see, we're getting referrals from GPs of well over 1,000. Slight decline in April, we think, because of Easter bank holiday. and seasonality, because our top 3 conditions include sinusitis and sore throat. So you'd expect them to tail off the nicer the weather gets. And we're still waiting for some additional data from the NHS to tell us exactly how many patients have walked in and exactly how many referrals we've had from 111. But as you can see, that's well over 1,000 appointments saved a month in Oxfordshire alone. Next slide, please. And again, please, Erica. So the CCA, the Company Chemists Association, they're a trade body that's behind the big multiples in pharmacy. So Boots, Rowlands, Superdrug, Asda, Tesco, Morrison. And they've been looking at all the data their pharmacies have been collecting. And actually, they're starting to see now patterns emerging from Pharmacy First. So they're saying that 90% of all the patients that are eligible get the care they need, which is great. 75% of eligible consultations result in NHS-funded medicine being supplied. And actually, only 1 in 5 of all the referrals come from GP. The other 80% are coming from walk-ins or 111 or emergency care. So that's really quite encouraging. And we are seeing from, well, they're seeing from the clinical records that the pharmacists are really adhering quite closely to the quite tight frameworks they have to work within. So we now know some of the things that we need to do going forward, and I'll expand on those in another slide. So next slide, please, Erica. Yeah, so what have we learned in the first 3 months? So we have learned that the most successful communities with Pharmacy First is where collaboration has absolutely been brilliant, where the pharmacists and the clinical directors and the practice teams have really got together and come up with a plan. And to help that everywhere, Bob has now funded what we're calling community pharmacy PCN leads. So we're going to have one pharmacist that works in a community pharmacy to really try to join all the dots together to try to get the best out of the pharmacies working with the PCNs locally. And by having some really great conversations and making sure that the process that's being used is absolutely spot on in the GPs and in the pharmacy. But what's also needed is we need to make more patients aware of the service. Hence, hopefully, while we're having this this webinar today, I'm also talking to the Bob's comms team to try and see what we can do locally, especially in those areas of inequality and deprivation, what we can do to really get that message out there. And obviously, the long-term plan is we educate patients around they can use their pharmacy more effectively and bypass 111 and the GP for certain conditions. And we see no reason why those conditions won't widen in the future. And obviously, while we're in a sort of the summer, it'd be really good, wouldn't it, to get this absolutely working right at this time of year. So by the time we do get to September, when winter pressures, we're busy with vaccinations and all the illnesses start to be amplified because of the weather, we can really make use of Pharmacy First across Oxfordshire. Julie's also facilitated a conversation with the UEC and out of hours to really start to understand how we can get them to refer patients to Pharmacy First as well. And of course, we really do need some great data so we can really dig in, understand exactly what medication is being given to patients by pharmacists and how many appointments that's saving, because that translates into quite a lot of money overall, but not just money, of course, it's quality of patient access, which is basically what this is all about. Next slide, please, Erica. Yeah, I think that's it. That's enough from me. So it'd be great to have some questions.
So you can either put questions in the chat or raise your hand if you'd like to ask a question. Thank you, David. That was really interesting.
There's obviously quite a lot of detail behind, what is a good clinical pathway, because there's 23 legal bits of paper that each pharmacist has to read and understand before they can give medication to a patient. But happy to expand on that.
So we've got Jackie has got her hand raised. Jackie, would you like to ask the question?
Hi. So I'm a work in a GP practice now, but I was a community pharmacist for a very long time. I'm just interested to see how the pharmacist on duty in that particular pharmacy deals with that consultation in terms of taking them out of the dispensary. Because I know when I was in community pharmacy, that was something that I found quite difficult to manage. If you're the only person on duty, how long are the consultations taking, and what kind of work is backing up and creating more pressure on the outside?
Yeah, great question, Jackie. And I think it's a team effort within the pharmacy. It's really important, especially where it's a walk-in patient, that the healthcare assistants or dispensers at the actual counter understand at least the basic principles of the condition the patients come in with. So there is a gateway point with each condition. So if it reaches a certain place, then they can introduce the pharmacist to the patient. And then every pharmacy has a consulting room where in private they can have a quality conversation. And we're finding that the average consultation is taking about 15 minutes. It obviously depends, but that's what we're finding at the moment.
Okay, so after the consultation has been carried out and perhaps they're getting some medication, what's the process then for the patient? How long are they waiting for, and what? Because I know from my work in GP, I'm getting some pharmacy first paperwork back, which I'm kind of documenting on the patient's record, to say that it's been prescribed elsewhere. But just sort of wondering how long that whole process takes, and how much paperwork is involved, really.
Well, it's all done through something called Farm Outcomes, which is basically an online template, which is similar to your EMIS system within the practice. So at the time of consultation, all the patient data is drawn through. We have access to a summary care record of the patient, so the repeat medication. That will actually enhance in the coming months, so we get access to more of that patient record. And then using the it's almost like a built-in flowchart on the template. So it's doing some red flagging, some triaging, some watch outs. It will lead the pharmacist through the very complex flowchart, so to speak, and ultimately lead then to a decision made, whether it's medication or to come back in a few days or onward referral to a GP or whatever. And then as soon as the button's pressed, you're right, there is now a digital pathway where the practice gets a record of that conversation alongside any medication that's been given to that patient. And you're probably seeing it a bit manual at the moment, but within the next few weeks, it will go straight into record with just one tick of whatever. I don't know what you see at the practice, to be honest, but one tick of that document at the practice end, it will go straight into patient record.
Okay, that's good. Yeah, at the moment it's just coming through as like into a DocMan file. Yeah, and I'm just
that's going to be automated over the coming weeks.
Oh, okay, brilliant. That's really helpful. Thank you.
Thanks, Jackie.
So there's a question in the chat from Vicky, which is about, I think, really about coverage of pharmacy provision. And Julie, I know you mentioned the review of the pharmaceutical needs assessment. Her question was, will there be more pharmacy firsts opening in central Oxford soon?
So yes, so thank you for that question. Most of our community pharmacies are offering the pharmacy first. We need to remember that it is limited conditions and limited groups of people within those conditions. And David's slide was very very apparent. So, for example, they can treat a woman with a urinary tract infection, but they can't treat someone who's pregnant and has a urinary tract infection. So there are things. So most community pharmacies do offer the service. If you go in and they don't, they should refer you to one that does. But the other way for people to check is to look on the NHS Service Finder, which details all the additional services, as David listed, that community pharmacy offer. So they should all be there.
Any other questions from anyone? Can we see?
There's another question in the chat from Sarah.
Yes, Sarah Wild, I think, wanting to clarify the different roles and remits, really. There's pharmacists working in PCNs paid for by the NHS. There are now lead pharmacists in private pharmacies liaising with PCNs. she wants to understand why the doubling of staff.
So shall I answer? So, and I can answer that as a true pharmacist, and it's good to know that there are others on the call too. So so as a community pharmacy, you can there are a number of disciplines you can go into. Previously, it used to be either working in hospital, looking after patients on wards, or working in a community pharmacy dispensing medication for those that have been seen by the GP. I'm sure you're all aware of the primary care networks, and the primary care networks have been allowed to also employ clinical pharmacists to work alongside the GP as part of the additional role reimbursement scheme, or ARRS. People will have heard that terminology. Now, those pharmacists working alongside the GP do things like medication reviews, that they help patients sort out their medication. They might do searches to find out who needs a blood test at any one time. So they do that sort of role and responsibilities. They are not able to offer a pharmacy first scheme, which is only available from your community pharmacy or your high street pharmacy, although noting David said that does include some of our online community pharmacies. The community pharmacy on the high street is someone that is there at any time. Any patient, any individual can walk into any pharmacy at any time and ask for over the counter advice. That advice might be for a simple condition like an itch, or for something more complex. Where a community pharmacy can't answer, they will refer back into the general practice. So I think what I'm saying is that actually community pharmacies do all different roles, whether they're in a community pharmacy or whether they are a clinical pharmacist or whether they are a hospital pharmacist, or all sorts of other things. Where a community pharmacist has expertise is responding and liaising with those patients that walk in and look for advice, and also in dealing with those ongoing dispensing of medications.
Can I just pick up Paul's question, please, Veronica and Julie? It's about increasing the number of pharmacists within a pharmacy, basically, and queues. So in the old days, not that long ago, dispensing items was actually quite a profitable part of the business for pharmacies. The current reality is now that dispensing items makes the pharmacy hardly any money whatsoever. So there's been a real shift between the time spent actually dispensing and the time spent doing face-to-face consultations with patients. So lots of new initiatives and different ways of working have come into play in most pharmacies now, where the pharmacist will spend less time dispensing or helping with the dispensing and actually spending more time at the counter with patients. And that's the right thing to do, because that's the skill set of that pharmacist. And that's going to happen more and more as we go towards the future. And when we see queues in a pharmacy, it may not be that the pharmacy is actually overwhelmed or busy. It may just be that there's some simple processes not in place, either in the pharmacy or indeed the practice. And that's where the system and the LPC can come into play and try to understand what's going on and support both the pharmacy and the practice and try to fix those issues. So seeing a queue isn't always what it seems like it could be showing.
So one question that's coming to Healthwatch a little bit more at the moment is around waiting times for prescriptions, but also shortages of medicines. Perhaps you could comment on your experience of that in Oxfordshire?
Yeah, well, two parts to that really. Supply chain, so the supply of medicines is a national problem, and I'm being frank now, it's probably the worst it's ever been. So there's over 200 items at the moment which are hard to get hold of, or where the pharma companies are putting the prices up and prices up. So the government's having to adjust pricing to ensure that pharmacies aren't dispensing medication out of their own pockets, basically. And that's we're making massive representations to the NHS and to the government to try to come up with a solution, but that's going to take an awfully long time. In terms of waiting for prescriptions, again, that's a process thing. So Julie pointed out the use of the NHS app, but there's also other things that pharmacies and practices can do. So encouraging the use of electronic repeat dispensing or electronic prescriptions. And there's still a few practices that hasn't gone all the way there yet. So hopefully we can help with that. Because, for example, if a patient's prescription is electronic, if for whatever reason they go on holiday or they need to go to a different pharmacy, they can get that prescription in any pharmacy they like because it's available in the cloud. If it's excuse me, if it's a piece of paper and that prescription's been sent to the pharmacy and it's been assembled, there's no real way that the patient can access that prescription. And that takes time. That takes longer for the prescription to be assembled. And by having a really efficient repeat dispensing system gives the pharmacy a couple of weeks, if it's a monthly prescription, to find the stock. Because what we're finding is that many pharmacies are spending far too long looking for medication to give to patients when they come in the next day or the next week, which isn't helpful for anybody, to be honest.
So we've got another question in the chat, which is around that sort of interface between the GPs and pharmacy in communication. And I know there's meant to be or going to be significant investment in smoothing that out. Perhaps you could update us on that one.
It says optician. Does that mean pharmacist, or is that should that say optician?
Yeah. No, I mean I guess it's an issue between all four of our primary care services. So whether that's the GP and the pharmacist, or the GP and the optician, or the GP and the dentist, or the dentist and the optician, you think of all the different combinations. We're probably the furthest forward with community pharmacy and the GP practice, in that community pharmacists can see a very high level summary record of the patient, and they obviously keep their own records in terms of what prescriptions have been dispensed. And linking back to sort of Jackie's question at the beginning, she currently gets a letter back from the practice, which then has from the pharmacy to say this patient has had X, Y, and Z. That then needs to be manually inputted. However, that is becoming electronic, an electronic update into the records in the GP practice. That's slowly being rolled out across our county. What Sarah refers to is the Rego system, which is a system by which optometrists, so your high street optician, can refer directly to the eye hospital, so that they don't have to write to the GP asking them to refer to the ophthalmology department. And that really just takes a step out, and is where our optometrists are really most skilled at being able to decide whether that patient needs to be referred for specialist advice. What we don't have very well is at the moment is our optometrists or our dentists being able to talk to GPs, or indeed them being able to talk to anyone else. We have made reference to that in our GP strategy, but it's probably relying on some national solutions to make it work.
Shall I talk about supply chain, Julie, Veronica? So what's driving the issues? So the way it works within pharmacies, they order all their stock through wholesalers. So there's probably about 4 or 5 really big wholesalers and maybe a couple of dozen smaller ones. and they get their stock direct from the big pharmaceutical companies, whether they're ones that are manufacturing very, very cheap medication, what we call generics, for pennies a box, or the very expensive medication, which could be thousands of pounds a box. Medication's made all over the world. So unfortunately, I'm going to have to mention the Brexit word. That's caused some issues. The free flow of medication isn't as free flowing as it was. And the UK government actually is very, very aware of trying to keep prices in check and very strict about the prices it will pay for medication. But when that means that another country or another market will pay more for that medication, the pharmaceutical company will supply the medication to the country or the market that's paying the better price. So a pharmacy then is beholden to the wholesaler being able to get hold of that stock. So when it's on order, they are literally waiting for the wholesaler to get an amount of medication from that supplier. And it's it's not as simple as that, it's very complex, but that's what it's like in a pharmacy. So you're hunting around 20 wholesalers, trying to find the one wholesaler in a part of the country that's got it in stock on that. It might have arrived that morning, and within half an hour, it's all gone. And it's awful and takes too much time. But you have to draw the line with pricing, otherwise the price of medication would literally go through the roof.
Dan, I wonder if you want to talk about any of this in relation to place and the work with health inequalities and the new models of primary care in Oxfordshire.
Yeah, well, I think a lot of them have been touched on there, Veronica. Yeah, thanks for putting me on the spot. For anyone that doesn't know, I'm Dan Leveson, Place Director for Oxfordshire. I think David's talked a lot about some of the work that we're doing is trying to make sure that the right people get the right care and support in the right places. And more often than not, and we do acknowledge some of the stuff that we've put in place, it's complicated to know where to go. So we're trying to help as much as possible, make sure that people get to the right place. So you'll have heard when Julie came to talk about developing integrated neighbourhood teams. So around building around primary care, so that having enough of the right people to focus on people that require more continuity of care. So people with long-term conditions, people who are frail, people who will benefit from different teams inputting to them and then supporting them that way. So that's an important part of what we're doing. And things like the Pharmacy First service actually frees up and enables GPs and other teams to do a lot of that work that's really critical, that we know is important, and we know continuity is important to some people, whereas for a lot of us, for people like me and many others, continuity right now doesn't really matter. Actually getting me to the right place, getting me to the pharmacist, getting me to the urgent care centre when I need something that doesn't require a team of people around me is really what we're focusing on doing. And this is all part of it, and it's really positive to hear David and Julie talk about the scheme, and we're at the foothills of it, I'm sure, and how we develop it. And equally, it's really important to hear people's experiences of these services as well, so we can keep developing. I've stopped because I think Jan has her hand up, as I was told, so bought a bit of time for Jan to think of a question.
Thank you very much indeed. As a patient, obviously this is a huge step forward in terms of patients and getting appointments, and obviously to be able to go to a pharmacy and get something dealt with rather than have to wait, however, for an appointment is a huge step forward. So I congratulate you on the work. However, my concern is, as a patient, do the pharmacists have access to my patient records? Because I know how careful the NHS is about anybody looking at your records, including yourselves, in order that they can safely treat a patient, quite honestly.
Yes, this is a quick answer. So as long as the patient has given consent for their records to be shared from their GP record, each pharmacist will have access to what we call local healthcare records now. So it's a summary, not the full record at the moment. So it's mainly your repeat medication, but it won't be long. Hopefully by August, that amount of information of that record will be expanded to the pharmacist. So they can also see acute medication as well. And that will help with antibiotic stewardship. So if a patient is constantly getting antibiotics from different pharmacies around the country, that'll be highlighted for the pharmacist to alert them that there may be something else happening here with this patient. So yes.
My other concern is that obviously you may have a condition that perhaps would be a contraindication to pharmacy
yes.
drugs that they would give you. So how
yes.
would that be dealt with?
In the same way it is now. So if a prescription is put together, that's the crux really of a pharmacist training. And Julie would testify to this. The analysing of contraindications of medication is paramount to what a pharmacist does. So picking up on that information within that record is really quite important sometimes. And don't forget, these are minor illnesses that we're dealing with, but it is there to look at.
Yeah. So presumably, if there was indications with the medication that was being given, I appreciate it's not going to be a huge range. Would they be asking questions of the patient about any other problems that they have?
Yeah. There's 23 what we call PGDs, patient group directions, and it's a legal document that the pharmacist has to sign to say they will follow and they understand. And built within then, for every piece of medication that can be given to a patient, all the exceptions, the contraindications, everything's built into that document. And that's part of the form filling exercise, the template that the pharmacist fills in at the time of consultation. There's lots of safety measures and safety netting in there.
Yeah, and in fact, in some cases it probably goes a little bit too far. So you might be, I think, 66 and have a urinary tract infection and want to go to the pharmacist for some antibiotics, but you'll be out of the scope of what the pharmacist can be doing. So for people who have been to the community pharmacy and tried to get advice and support under pharmacy first, they might not be successful because the guidelines or the policy within which the pharmacist is operating is quite tight and rigid. And we really hope from Jackie's question that actually we're starting small and contained, but actually that will expand upwards and outwards as the number of conditions, the scope of what can be treated, or the scope of the people that can be treated can expand. So I think it's quite small and contained initially. There's only a certain number of medications that can be given. There's only 7 common conditions, as it's sometimes referred to. But actually, I think this is the beginning of really establishing the community pharmacy on the high street as a one-stop shop, as a port of call that you can just walk into, get advice, and get on with your day.
Can I just ask? So, would they be able to give an antibiotic, for example?
They can give some antibiotics
if you
for
were
some
within
conditions.
that scope.
If you were in the scope, absolutely. There are a handful of antibiotics which are allowed to be prescribed, certainly for a urinary tract infection, for example.
Yeah, that's what I was thinking. Yeah, absolutely. Yeah. Okay, then thank you, and thank you for thinking that I might be 66.
No, sorry, I was just trying to give that as an example.
I'm only joking. Well, I hope you're not.
No, it's a good, because Julie, the earache condition is only for children, but under 18, which you think is quite weird because the skills are exactly the same whether you're looking at a child's ear or an adult's ear. So you can imagine that could be the next one that gets switched on, but it has caused confusion at the beginning. So adults are walking in with an earache. Oh, you can look at my ear and give me an antibiotic. Actually, we're going to do children. We're not allowed. So we have to send them back to the GP. And we've worked really hard with GPs to help them understand those tight pathways are as well. And there's a whole tool they use to to make sure they don't inappropriately refer patients into a pharmacy and cause a loop, basically. So that's worked actually really, really well where the process is in place.
Yeah.
Thank you. Yeah, could I just quickly say that when you do your, I mean, obviously you've thought a lot about this, and in terms of sort of PR to the general public, can you ensure that people, you know, realise, like the questions that I've asked, is it safe? You know, can they get what they need? Because a lot of people will be thinking along those lines and then still go and make a piss of themselves at the GP
Absolutely,
when they need it,
yeah.
basically. So it's just a point really that I think is important. Thank you.
Absolutely, thank you.
Thank you. I mean that those things came up in Healthwatch, a report we did on community pharmacy, of people still not quite understanding the role of the pharmacist and how to access, and just that need for continuing to educate and inform the public about these new roles. We've got another question here from Montgomery House, which is queues outside pharmacies are long in Bicester, but it would seem sensible to add a remote consultation service for Pharmacy First. Are there any plans in place for this?
So all the minor conditions, apart from the earache one, where you need an otoscope to look in, can be done by video link. So that can be done. Whether the pharmacy is doing it or not is up to them. But when we talked about distance selling pharmacies, so there's 100 or so of them across the country, they can all do those 6 of those 7 conditions by high-speed video link, FaceTime or Teams or whatever. So that is in there now. And some of the other conditions that aren't part of the Pharmacy First sort of face-to-face stuff can be done by phone, where quite a few pharmacies are doing those just to give advice. But I take on board, obviously, some pharmacies are busier than others, and especially Bicester, one of those areas where there's been some changes recently, which has probably caused a little bit of a transitional period for the patients there.
So, have we got any other questions before we wrap up, I think?
I think it's been touched on, but Jackie had a question about other conditions being added to Pharmacy First.
Yeah. So do you anticipate other conditions being added to Pharmacy First?
Eventually. Yeah. I would suggest from the 1st of April next year, we may see half a dozen more, perhaps. Depends on how well it goes this year. But early indications are it's going well.
And there's a full evaluation, a full national evaluation of this scheme to look at. You know, we've all heard about overprescribing of antibiotics and components like that. So there will be a full review of antibiotic prescribing by the Pharmacy First scheme, as well as, you know, what's worked, what hasn't worked. So I too expect it to be expanded. Early indications show that community pharmacies aren't overprescribing antibiotics. So yeah, so I think it's a watch this space.
That's great. Well, thank you so much to all the speakers for a really interesting talk about you know, the emerging potential really of this increased work and the way it can help support primary care generally. I just wanted to highlight our next webinar, which we're running on June the 18th. And again, we will be pleased to have Dan Leveson and Sarah Adair from the Integrated Care Board. And they're going to come and talk on how patients and the public can be involved in design and delivery of healthcare services in Oxfordshire.
Oh, Veronica, you've flipped onto mute, it seems.
Where did I cut off? So, did you hear that?
The trailer for how amazing the next one's going to be.
Yeah, how amazing the next webinar is going to be on patient engagement anyway. So it's a really good opportunity for people to come and have that discussion about how patient and public can be more involved in you know, supporting health services in their development and delivery.
Yeah, and with that in mind, I did put a link to I write a monthly blog if people really have nothing better to do with a 2 minutes in their month, do check out my blog. I put, and you can subscribe to it, so it'll go straight into your inbox or junk.
Good. Well, thank you very much, everybody, for coming on a Tuesday morning, afternoon, and thanks to the speakers as well. It's really interesting. So as I said, this video will be displayed on Healthwatch Oxfordshire website, so you will be able to see it again at your leisure as well. Thank you, everybody.
Thank you very much.
Thank you.
Everyone.
Thank you.